This recorded review will be going over Med-Surg 1, Exam 8 Study Guide. Starting with Chapter 2, the integumentary system. Explain the pathophysiology behind gray hair. We can see this on page 983. A decrease in the number of melanocytes at the hair follicle causes gradual loss of hair color. Would it be appropriate to pull a draw sheet directly out from under a patient? Why not? No, it would not be appropriate, and we can see more about this on page 985 in box 42.2, measures to prevent skin tears and protect fragile skin. We should be using a lift sheet to move and turn patients. How should the nurse alter their bathing routine for a patient that is very old? We can see this on page 984 in the red older adult care points. Older adults who have dry skin do not need a full bath every day. Cleansing the axilla and genital rectal area between bathing days should be sufficient. Older adults should use a mild lotion-based soap or body wash for bathing. After showering or bathing, a lotion or cream that helps seal in moisture should be applied while the skin is still damp. Moisturizing lotion or cream should be reapplied at bedtime. You can assist the older adult patient to establish a regular routine of massaging oil, cream, or oily lotion onto the skin. What are some tips for protecting the skin against sun exposure? Check out the green health promotion tips on page 984. So we can see that on page 984. It's important to note that you can become sunburned on a cloudy or overcast day. Light, loosely woven clothing will not give you adequate protection from the sun's rays. And of course, most obvious and in the bolded text, never use a tanning booth. There is an 8-fold increased risk of developing melanoma for patients under the age of 36 who use tanning booths. What is an important step when applying lotion? We can see this on page 992 in box 42.3, guidelines for applying topical medications. Look at lotions. Lotions are powders suspended in water. They will leave a residue once the liquid evaporates from the skin. This residue should be washed off before a fresh dose is applied. Define shave biopsy. We're going to go back to page 986 for this, and you can see the bolded text. A shave biopsy can be done by shaving a top layer off a lesion that rises above the skin line. How would the nurse interpret a skin turgor return time of 5 seconds? We can see this on page 988. Skin that takes longer than 1 to 2 seconds to return to place is called poor skin turgor, and it indicates dehydration. What is ABCD when screening for melanoma? We can also see this on page 988 in the blue patient teaching box. When assessing for melanoma, check for the ABCDs. A, asymmetric. B, irregular border. C, color change. And D, diameter greater than 1/4 inch. What nursing care is required for an open dressing? We can see this on page 991. Open compresses must be changed repeatedly and are never allowed to dry. They usually need to be remoistened every 20 to 30 minutes. Chapter 43, Care of Patients with Integumentary Burn Disorders and Burns. What is an important nursing action to include when bathing a patient with poison ivy dermatitis? We can see this on page 996. The skin should be patted dry rather than rubbed dry. What should the patient with acne rosacea be instructed to avoid? We can see this on page 997. Factors that cause facial flushing will precipitate worsening. Tea, coffee, alcohol, especially wine, caffeine-containing foods, spicy foods, sunlight, and emotional stress will cause flare-ups, and all should be avoided. What are the cautions for the use of Accutane? We can see this on page 997. This drug was initially marketed under the trade name Accutane, but after black box warnings and increasing numbers of reports of adverse events, including GI concerns, birth defects, and increased rates of suicide, Roche discontinued marketing Accutane in the United States in 2009. Isotretinoin is used only for severe cystic acne that is resistant to all other forms of treatment. There are serious adverse side effects, including organ damage and mental problems. How should a patient with acne vulgaris be advised to wash their skin? We can also see this on page 997. The face should be washed gently with a mild soap. Describe PUVA therapy for psoriasis. We can see this on page 998. Combinations of artificial UV radiation and a coal tar product commonly are prescribed for severe cases. This typically requires hospitalization so that the dosage of each component of therapy can be precisely measured. A form of therapy called PUVA combines the application of one of a class of drugs called Psoralens, which penetrates the skin with exposure to UV type A light. What devices can be helpful to keep in the home of a patient suffering from psoriasis? We can see this on page 999 in the bolded text. The skin should be kept as moist and pliable as possible. Humidifiers to increase moisture in the environment are sometimes helpful. Describe the signs and symptoms of herpes zoster. We can see this on page 1001. Herpes zoster begins with vague symptoms of fatigue and low-grade fever, as well as a possible loss of appetite. About 3 to 5 days after onset, small groups of vesicles will appear on the skin. They are typically found on the trunk and can spread halfway around the body, following the nerve pathways leading from the spinal nerve to the skin. The vesicles will eventually change from small blisters to scaly lesions and are then accompanied by pain and itching. The lesions typically affect only one side of the body or face, and the pain from shingles can often be quite severe. The pain of post-herpetic syndrome is not easy to control. Why is it better to start treatment earlier rather than later for herpes zoster? We can also see this on page 1001 in the bolded text. The earlier the condition is diagnosed and treatment begins, the better are the chances to decrease the amount and duration of associated pain. What are some non-pharmacological techniques the nurse could use to relieve a patient of their shingles pain? We can also see this on page 1001. Teaching imagery, deep muscle relaxation, or the use of distraction activities can help decrease pain. How should you instruct the parent of a patient with lice to do laundry? We can see this on page 1003. Laundering in hot water and machine drying using the hottest cycle is effective. The nurse is bathing a patient and notes a large black raised macule on the patient's back. How should the nurse proceed? We can see this on page 1006 going into page 1007. While performing daily care of patients, you often are in a position to notice these lesions in their early stages, and you should do your best to persuade the person with that lesion to seek prompt medical attention. If the patient is hospitalized, notify the healthcare provider. How can applying light mechanical action via a whirlpool bath help pressure ulcers heal? We can see this on page 1001. Normal saline or other non-toxic, 1011. Normal saline or other non-toxic solutions, such as Surg cleanse and the light mechanical action with sponges or irrigation equipment, is a way of cleansing that prevents the disruption of granulation tissue. This is known as a whirlpool bath. What type of dressing should the nurse select for a stage 1 pressure ulcer? We can also see this on 1011. Wound dressings will be selected according to the characteristics of the wound. You should choose a dressing that keeps the ulcer moist and the surrounding skin dry. The nurse should use a transparent film dressing on a red, unblanchable coccyx, which is a stage 1 pressure ulcer. How is electrical stimulation an effective treatment option for a pressure ulcer? So we can also see that on page 1011 going into page 1012. Application of electrical stimulation increases the rate of healing of pressure ulcers, venous leg ulcers, and diabetic foot ulcers. Application of an electrical current to the skin has been in clinical use for several decades. The therapy requires bulky equipment for generation and delivery of the electrical therapy. The nurse would interpret a creamy yellow discharge from a wound as what type of possible bacterial infection? We can see this on page 1012 in table 43.2, the color of purulent exudate and the probable pathogen. Look at the creamy yellow exudate. It could indicate a staphylococcus infection. Chapter 5, Drugs for Bacterial Infections. Why can a patient be susceptible to a yeast or fungal infection after taking a course of antibiotics? We can see this on page 69. Antibiotic use can upset the balance of the normal flora in the body, and it can cause yeast or fungal infections to occur. The breastfeeding mother asks you if she can continue to breastfeed while taking antibiotics. What is your response? We can see this on page 70 in the green lifespan considerations box. Breastfeeding should be avoided during antimicrobial therapy because most of these drugs are excreted in breast milk, exposing the infant, who may not have an infection, to the actions, side effects, and adverse effects of that drug. What does broad-spectrum antibiotic mean? We can also see this on page 70. Drugs that are effective against more types of bacteria, including gram-negative and gram-positive bacteria, are known as broad-spectrum drugs. Broad-spectrum antibiotics have a high degree of activity against many different organisms. Why do we perform a culture and sensitivity prior to starting antibiotic therapy? We can see this on page 69. Bacteria are often stained, cultured, and tested to determine which drugs are effective against them. This is known as antimicrobial sensitivity. A specimen of the infective material will be taken for culture and sensitivity testing. This should be performed before any anti-infective therapy has begun. Which antibiotic would work best for a Group A beta hemolytic streptococcus infection, or Group A streptococci? We can see this on page 73. Look at number 1. Natural penicillins, like penicillin G or penicillin V, can combat non-beta lactamase producing gram-positive cocci. This includes Streptococcus viridans, Group A streptococci, Streptococcus pneumoniae, and anaerobic streptococci. What is the most common side effect of penicillin and many other antibiotics? We can see this on page 73. The most common side effect of penicillin and many other antibiotics is simple diarrhea of 2 to 4 loose stools daily. Antibiotics used to treat a penicillinase infection would need to be resistant to what organism? We can see this on page 70. Beta-lactamases, or penicillinases, are enzymes produced by some bacteria that give them resistance to beta-lactam antibiotics. This would include penicillins, cephalosporins, monobactams, and carbapenems. So, antibiotics used to treat an infection caused by a penicillinase-producing organism must be penicillinase resistant. What is an important educational point nurses must address when women of childbearing age are prescribed antibiotics? We can see this on page 71 in box 5.1, General Nursing Implications for Antimicrobial Drug Therapy. If a female patient is on oral contraceptives and does not wish to be pregnant, an alternative or additional method of contraception should be recommended while taking antibiotic therapy. What is an adverse effect of cephalosporin therapy, and which patients would need to be monitored more closely for this? We can see this on page 75. Patients who are allergic to penicillins have a risk of allergic reactions to cephalosporins because, that's going to be the next bullet point. For this current bullet point, what is an adverse effect of cephalosporin therapy and which patients would need to be monitored more closely for this? You can also see this on page 75. Nephrotoxicity has been reported with some cephalosporins, and the incidence is greater among older adult patients and those with poor renal function. So those are the patients who would need extra monitoring, those with poor renal function and our older adult population. Next bullet point, which drug has cross-sensitivity with penicillin? And what should the nurse do if the patient is allergic to penicillin yet still prescribed this drug? So we can see this on page 75. Patients who are allergic to penicillins have a risk of allergic reactions to cephalosporins because cephalosporins are structurally similar to penicillins. This is known as cross-sensitivity. If a cephalosporin must be used, it needs to be used with caution. Never give cephalosporins to a patient who has had an anaphylactic reaction to penicillin in the past. You should inform the provider immediately if the patient is allergic to penicillin and prescribed a cephalosporin. You should do this before you administer the drug. Your patient develops hives after taking antibiotics for 4 days. What should you do as the nurse? We can see this on page 72 within box 5.2. Instruct patients to stop taking the antimicrobial drug and notify the healthcare provider if a rash or hives develop. A drug allergy can develop at any time after the patient has begun treatment. If the patient develops a rash after antibiotics, ask them if they have ever had a rash while taking any other drugs. What is the proper way to give IM penicillin? We can see this on page 75 in the purple top tip for safety. With all IM injections, including penicillin, use the Z-track method and aspirate before injecting the drug. If blood appears in the syringe, remove the syringe, dispose of the drug, and prepare another dose. What is the drug of choice to treat Clostridium difficile? What class of antibiotics is this in? We can see this on page 76. Vancomycin is used to treat MRSA and other drug-resistant infections. Vancomycin has an oral form that is used to combat the pseudomembranous colitis caused by C. diff. Vancomycin is in the class of cell wall synthesis inhibitors. Your patient is receiving IV vancomycin and begins to develop a flushing red color over their face, neck, and chest. What do you do? We can see this on page 76. Vancomycin often causes flushing and hypotension. An unusual response is a deep red rash on the upper body, known as red man syndrome. This reaction is a response to the histamine release. Slowing the infusion rate and pre-treating the patient with antihistamines and an H2 receptor blocker can offer protection against red man syndrome. Do not stop Vanco for red mans. Instead, call the provider and slow it down. It is an uncomfortable but expected side effect. Chapter 6. Drugs for tuberculosis, fungal, and parasitic infections. How is TB spread? We can see this on page 84. TB can be transmitted to human hosts by other infected humans and, uncommonly, by cows or birds. Droplets ejected during coughing or sneezing are inhaled by an uninfected host. Once the bacterium is inhaled, it rapidly multiplies in the oxygen-rich lung tissue. Describe the pharmacological action of isoniazid. We can see this on page 86 in table 6.1, first-line drug therapy for tuberculosis. Isoniazid kills actively growing myobacteria outside the cell and inhibits the growth of dormant bacteria inside macrophages and granulomas. Isoniazid inhibits enzymes needed for the growth and reproduction of TB. What type of treatment regimen would you expect for a patient with active TB? We can see this on page 85. The first-line TB drug therapy recommended by the CDC consists of isoniazid, rifampin, pyrazinamide, and ethambutol for the first 8 weeks. This is the initial phase of treatment. The continuation phase lasts another 18 weeks, during which the patient takes INH and rifampin daily for 5 days a week, or 5 days a week. There are 3 more treatment regimens in the CDC guidelines that should be used for patients with HIV or AIDS or when treatment is difficult. So, in a nutshell, a patient with active TB can expect long-term treatment with several anti-tubercular drugs. What should patients taking rifampin be taught to avoid? We can see this on page 86 in table 6.1. Take a look at rifampin and the nursing implications. Remind patients to avoid drinking alcoholic beverages and acetaminophen while taking this drug because its liver-damaging effects will be potentiated by alcohol or acetaminophen use. Describe the action of azoles. What are these used to treat? We can see this on page 91 in table 6.3, examples of common antifungal drugs. Azoles alter the cellular membrane of the fungus by depleting a lipid-like substance which damages the fungus and keeps it from reproducing. In a nutshell, azoles alter the cell wall of the fungus. They're used to treat fungal infections. Why is it recommended to brush teeth and tongue prior to ingesting an antifungal oral lozenge? We can see this on page 92 within box 6.1, teaching points for patients using topical antifungal drugs. Look at oral lozenges. Patients should brush their teeth and tongue before using the tablet or troche to remove as much of the organism as possible so that the drug can come into direct contact with the affected area. How should the patient be instructed to use an antifungal vaginal cream? We can also see that on page 92 within box 6.1. Vaginal creams or suppositories should be placed just before going to bed to help keep them within the vagina longer. What are signs and symptoms of liver problems after taking an antifungal agent? We can see this on page 94. Notify your healthcare provider if you have dark urine, light-colored stool, or yellowing of the whites of the eyes, because all of these are signs of liver problems. Why should patients taking fluconazole be instructed to monitor themselves for a rash while taking this drug? We can see this on page 91 in table 6.3. Fluconazole. You should instruct patients to monitor for a rash, redness, or blistering because this could indicate a serious medical emergency called Stevens-Johnson syndrome. If these symptoms occur, they must notify the healthcare provider immediately. Which drugs are used for malaria prophylaxis? We can see this on page 94 and page 95. On page 94, the CDC has a prophylactic treatment guide for patients or persons traveling to areas where malaria is prevalent. And on page 95 in table 6.4, look at for malaria prophylaxis. Notice that primaquine can be given for malaria prophylaxis. What is an expected side effect of antiparasitic agents? We can see this on page 94. All drugs used to treat parasitic infections can cause nausea, vomiting, headache, anorexia, diarrhea, or GI distress. When would a patient be expected to take antimalarials without an active infection? So I read that one already, but that's on page 94. The CDC also has a prophylactic treatment guide for patients traveling to areas where malaria is prevalent. Why is ethambutol not prescribed to patients unable to report visual changes? What is a teaching point that you should stress to the patient prescribe this drug? We can see this on page 88 in the green lifespan considerations box. Children who have active TB or who are heavily exposed and require prophylaxis are prescribed isoniazid, rifampin, and pyrazinamide as first-line therapy. Ethambutol is not prescribed for infants or young children because they are unable to report visual changes that indicate a complication that could lead to permanent blindness. So patients must be able to report visual changes when they're prescribed ethambutol. Also note on page 89 some patient and family teaching. Patients should not drink alcohol for the entire duration of their TB treatment because these drugs can damage the liver and the damage will be worse when alcohol is consumed. Patients should also not take any other drugs without the knowledge and permission of their healthcare provider. Chapter 7, Drugs for Viral and Retroviral Infections. How do antivirals work? We can see this on page 101. Antivirals do not kill the virus, but rather stop viral reproduction. Why is it important to know if a patient prescribed Relenza has asthma? We can see this on page 102 within table 7.1, antiviral drugs for influenza and the herpes simplex virus. Take a look at Relenza or zanamivir. It is a neuraminidase inhibitor. Look at the nursing implications. Before giving zanamivir or Relenza, ask patients if they have asthma, because this orally inhaled drug can cause bronchospasms. Why should a patient taking Simitril be advised to monitor for confusion, changes in vision, and other cognitive side effects? That 4 is just a typo there. We can also see that on page 102 within table 7.1. Take a look at amantadine or Simitril. Nursing interventions or implications include observing patients for confusion, hallucinations, nightmares, and depression, because these drugs will cross the blood-brain barrier and can cause CNS side effects. Amantadine can have severe CNS side effects, including worsening glaucoma. Which drugs are beneficial for preventing influenza virus after exposure? We can see this on page 101. The 2 types of drugs used to treat influenza are neuraminidase inhibitors, like Tamiflu and Relenza. Those that can prevent the virus from opening the outer coat would include amantadine and rimetadine, flumidine. So flumidine would be the drug of choice here to prevent the influenza virus after exposure. Rimetadine, also known as flumidine. What is the only drug prescribed to treat RSV? We can see this on page 103. The only drug approved for the treatment of RSV infection is ribavirin, or Virazole. What should you tell the mother of a patient going home with a prescription for aerosolized ribavirin, or Virazole? So we can see this on page 103 within table 7.2. Antiviral drugs for CMV and RSV. Take a look at ribavirin, or Virazole, as well as the nursing implications. You should close the door to the patient's room to prevent the drug from entering the hallway and endangering others. If you are pregnant, do not give this drug because it can cause severe birth defects or fetal death. Why do you need to know if the patient prescribed acyclovir has a true allergy to milk? We can see this on page 102 within table 7.1. Take a look at acyclovir and the nursing implications. Before giving acyclovir, ask patients whether they have a true milk allergy, because this is a contraindication to acyclovir therapy due to the cross-reactivity of the antibodies. Adefovir, or Hepcera, can cause liver toxicity, so what should the nurse monitor for? We can see this on page 104 within table 7.3, drugs for hepatitis B and hepatitis C. Take a look at adefovir, or Hepcera. It is a DNA polymerase inhibitor. Look at the nursing implications. Assess patients for yellowing of the skin and sclera, and for elevated liver enzymes, because the drugs are toxic to the liver. What patient teaching should the nurse provide to a patient newly prescribed efavirenz, or Sustiva? We can see this on page 108 in table 7.4, examples of antiretroviral drug therapy for HIV infection. Take a look at efavirenz, or Sustiva. It is a non-nucleoside reverse transcriptase inhibitor. And look at the nursing implications. Instruct patients to notify the prescriber if a sore throat, fever, various types of rashes, blisters, or multiple bruises develop, because these are indications of a serious adverse drug effect. The nurse should hold the dose and notify the provider. Your HIV positive patient states that they will be cured when they finish their antiretroviral therapy. What is your response? We can see this on page 107. Antiretrovirals are an important group of drugs that slow the growth or prevent the duplication of retroviruses. They do not cure HIV or AIDS, but they do help patients live healthier, longer lives by interfering with the ability of the retrovirus to replicate and slowing the production of new retroviruses. Antiretrovirals will limit the progression of HIV, but none of the drugs will kill the virus. Remember that a retrovirus is a viral organism that carries special enzymes, including reverse transcriptase, integrase, and protease, and it will use RNA instead of DNA as its genes to reproduce. The retrovirus inserts its genetic material into the host cell's DNA.